On this episode of the Ask Mike Reinold Show, we talk about joint manipulations, when we use them, if we use them, why we use them, everything you want to know.
The Ask Mike Reinold Show. Helping people feel better, move better, and perform better.
Before we get to the podcast, I wanted to make sure you knew about my free online course on the Introduction to Performance Therapy and Training. If you want to learn how to get started optimizing and enhancing performance, this is the course for you. Head to mikereinold.com/performance to sign up today. Welcome back, everybody, to the latest episode of the Ask Mike Reinold Show. We're up in Massachusetts, in Boston, at Champion PT Performance. Dan Pope, Lisa Russell, Mike Scaduto, Lenny Macrina, Dave Tilley here answering all of your amazing questions and doing it various ways, right? The listeners, the watchers, the readers, we have all these different ways on how you can now engage with us, engaging with your engaging
virtual reality
questions.
coming soon. Yep.
Wow, that would be amazing.
Sitting here,
and that would be amazing. You get to sit here with Dave Tilley and answer questions.
Yeah,
Len,
careful what you wish for.
why don't we introduce the students today?
We have students today. Yes, we do. We have Austin Riff from Franklin Pierce University. We have Andrew King, also known as King, from the University of Hartford. And we have Joe Goetti from Virginia Commonwealth University. I completely botched that, by the way.
Nice. Who's
Nice.
up today? Goetti?
Goetti.
That's not your name, is it?
No.
Yeah, it's not. That's not your name.
No, family.
I'm never gonna not remember that. So, yeah, way to not correct it too, Len. Just going with it.
Power through.
It's like, don't care about you. I like that. That's perfect. All right, Goetti.
All right, Nick from New York asked, what are your opinions on manipulations? Do you use them, and how do you incorporate them into your treatments?
Awesome. Lenny, I feel like you're very manipulative.
I like manipulating people.
So, all right, so we'll say joint manipulations, not mental manipulations.
Oh, then I get nothing.
But, so what's our opinions on joint manips? And do we use them? When do we use them? Stuff like that. So, all right, who does manipulations? Okay, happens, right? Yeah, it's probably less than we had at one point. Okay, so for those that do manipulations, let's start with that. Like, what do you manipulate and why? And is there anything you won't manipulate? I don't know where to start with that. But Mike, you want to start? What are your big joint manips that you perform?
Very oftentimes, I'd say 90% of the time, it's a thoracic spine, probably a PA manipulation. And I'm relying on my assessment techniques to decide if I feel like it's a hypomobile segment that is limiting their range of motion grossly into either thoracic extension or thoracic rotation or something like that. I think I try and get a global picture of the patient. Are they more hypomobile in general, or are they a hypermobile person with excess motion? Typically, I would steer away from a manipulation in that type of person.
Nice. Good thought process. I like how you make that decision. So it's not just manip everything, it's make sure it's the right person. And, to comment on your thoracic spine manipulation, if there is an area that shows some efficacy in the research, I think thoracic spine manipulations are probably one of the bigger ones, right? Lots of good manips. Dan, you probably have some references off the top of your head, but doing a thoracic spine manip to increase overhead mobility and to decrease shoulder pain and stuff, has been shown. So I think that's a great one right there. Anything else, Mike, other than thoracic?
I don't think so. So I said 90% of the time, it's probably 100% of the manipulations that I do are thoracic spine, but I don't do it 100% of the time.
Yeah, nothing wrong. Yeah, no, that makes perfect sense. How about you, Dan? What do you manipulate? Anything else?
Every so often, I'll manipulate a cervical spine. A couple thoughts here. I don't think it's risky necessarily. The risk of causing more serious effect is very low, although it can happen. The one thing I will say is I looked into this myself to figure out just how dangerous this is, and again, it's not very risky, but you can also cause problems by doing a mobilization of the neck, right? So I would say that you just have to think about the patient in front of you to figure out whether or not you think you should be doing mobilizations or manipulations of the cervical spine in general.
Right.
A lot of times for me, the cervical spine is more patient buy-in, so if someone really wants it and I think it can be beneficial. Certain conditions where it might be helpful, things like TMJ could be a good one. Oh, someone's calling me right now. Yeah.
Wow.
TMJ could be a good
Somebody
one.
needs a manip real quick.
Yeah, cervical spine. I thought I'd turn it off. I'm sorry. Those can be decent areas, but generally it's for someone who really wants it and I feel is a healthy candidate for it. And then again, it has to fall into the clinical reasoning process of whether or not I think there is a joint restriction that can be utilized, could be benefit from that.
I like that. There's actually a study that showed that now I'm forgetting off the top of my head, but I think I wrote a blog post about this a while back, that one of the primary factors on whether or not a manipulation was something you should include and would have a successful outcome is the person's perceived benefit of the procedure. So meaning if they didn't think it was going to work, it didn't work, and if they did think it was going to work, it did work.
Yeah.
So I don't even know what that says. We can hack that out a lot, but you said that, yeah.
One of the things I will say really quick is that oftentimes we're thinking, okay, I have to mobilize the stiff segment, that's why I'm using manipulation. What we're probably doing is a short-term effect. So again, I don't know that I would manipulate a hypermobile joint, especially if I may cause some sort of injury. But what I'm thinking about when I'm doing a manipulation is I'm probably having a neurophysiologic effect, right? And I'm guessing this is one of the reasons why people have less pain reaching overhead, less pain-free grip after manipulation, is because globally we cause a change in probably sensitivity, right? And these studies are done in pressure pain threshold. That was my research project that I did for my graduate degree, is that if you manipulate someone's spine, right, let's say it's lumbar spine or thoracic spine or cervical spine, you cause global changes in pressure pain threshold. In other words, you have less pain, your pain threshold goes up, your sensitivity goes down. So if I have someone who has a pain problem and I'm trying to decrease that pain, albeit maybe temporarily, I'm thinking about manipulating, and not just because I have a stiff segment per se.
Right, and you see here how there's so many levels of clinical reasoning that we're kind of talking about here. That was awesome. Any preference, upper versus lower cervical? Sounds like you're not scared of manips. Are you afraid of upper cervical, or have you already kind of answered that by saying no?
I guess not, but it's always in the back of my mind, and I'm doing it very rarely, and I'm doing it in young, healthy people, generally.
Right.
I'm definitely not doing it in someone who has cardiovascular disease or, obviously any red flags in general. I'm not going to do that, but yeah.
I feel like in my experience with cervical, that person that wakes up and they can't move their head to the right or whatever direction, they just can't move their head. A lot of them will want to run to a chiropractor or anybody really and try to get that manipulated. But I find that if I try to do that too early in the sequence, that sometimes it helps for a second, right, for a couple hours or something like that, but then there's this reflexive kind of spasm and tone that happens from it, and it almost gets worse a little bit here. So I would say I don't manipulate that often. I don't manipulate as much as I used to. For cervical manipulations, I actually find that I avoid it a little bit initially, and then once they're down and now, the pain and the spasm and the guarding's down, but they still have some hypomobility, then that's when I would probably apply it. And that's, very few and far between. Maybe with my patient population too, but but I definitely feel like I do it less. Let's shift gears a little bit. How about lumbar spine? Anybody do lumbar? Dan does. Yeah, you do. Dan does everything. I like it.
I don't know. I'm super unique in this because the people that I treat are typically hypermobile gymnasts or dancers or things like that, and I treat a lot of people with spondies, and so I've heard of circumstances where they fit the clinical prediction rule, or they had this acute low back pain that wasn't below their knee, all this kind of stuff, and they got manipped, and it's the worst possible thing they could do.
Right.
And I have a lot of people who are hypermobile who when they get taken to enter and you get a lumbar manip, either gymnasts with different people or whatever, they're I feel like you said with the neck, I feel better for an hour, and then I actually feel much, much worse after. And so you have to kind of use your critical thinking skills about why is this person having this probably relative hypermobility at their lumbar spine, making up for a lack of hip mobility, or maybe their core is not stiff enough during their activities or whatever. So I would say, you can use them. I think if I have a general patient who has more of a classic disc issue or something like that, it's more of my kind of options. But for most people, I'm kind of thinking about some other things first.
Yeah, I don't want to say I ever have strict contraindications. There's only very few rare things that I kind of feel that way about, but I kind of thinking in my head, I don't want to do lumbar manips anymore. Yeah. Just me personally, I just feel like the majority of times somebody has some pain is there's either some hypermobility, right, or soft tissue restrictions. But it's not really joint as much in the lumbar spine. So I just feel like and maybe again, maybe it's my patient population, but I just feel like, you know, that's barking up the wrong tree a lot of times. So I've stopped. I don't do lumbar that much. Yeah, Dan?
I was going to say is if you start looking through the Cochrane reviews about manipulations, they're not that powerful for the average person that's in front of you for low back pain.
Right.
So it's not, you know, to get rid of that, I don't think is a bad decision, right?
Yeah, sure.
Yeah.
Yeah, and then, you know, I mean, you know, extremity-wise, probably not far off, right? I think a lot of times, like, our joints are hypermobile, right, not hypomobile. So, you know, a lot of times I think we focus on soft tissue a little bit more here, is what I'd say. Anybody else, anything to add?
I think Dan nailed it. I don't think I could have said it better. That I don't really think I used to be in the world of, oh, I see a lot of hypermobile people. Why would I manip? Are we really making a segment more hypermobile by a quick manipulation? Like, you're dealing with bone and collagen and everything else there. When we talk about the knee, we talk about having to load it low load long duration for hours at a time, and all of a sudden we could do a quick thrust to a lumbar spine or a thoracic spine, and we're creating more mobility. Are we creating more mobility by stretching tissue, or by what you said, kind of a neurophysiological response where maybe sensitivity goes down, pain goes down, or the ability to detect pain goes down, so you can do more? I'm in the world of, and maybe it's my patients, that it's a soft tissue issue, meaning muscular tightness. So to me, doing a manip, yeah, it may feel good. I do thoracic manips a little, and it's usually by accident, like doing something on somebody and their joint pops. I'm like, oh, sweet, you know. And I treat a lot of hypermobile people.
No judge.
I am, yeah. I mean, that's my joke is, save you $35 going to another practice. But I don't know. I think we think about it incorrectly, but the perception that somebody is going to benefit from it, like anything else, if they think it, it's probably going to be more likely to occur, like a positive effect. I think anything else, there's a reason why people come in here after going somewhere else, and we don't do anything differently than anybody else, but I feel like our results may be a little bit better, or at least I perceive that, because the person thinks they're going to get better. So you got to play those mind games.
All perception.
It
Lisa,
really is, yeah.
I think I saw you say no, that you don't manip.
I'm
No.
talking about rowers and stress fractures on the ribs, is that a thing, right?
I don't.
Well, why? Why don't you manip?
I have way more success in getting people to feel better with soft tissue and teaching them like self mobility, breathing, like any of that kind of stuff. Because you get, I mean, rowers get low back pain like they'll come to me and say like, oh man, can you just like crack my back, like I'm so stiff.
Yeah.
It's like, well, you're stiff because your muscles are all tight because you're really tired, and
Right.
you know, it's not I get way more success in hitting the soft tissue and doing mobility work than manipulating anything. So I haven't spent the time to get good at it, so I don't really do it.
Yeah, I think a lot of people have that barrier. It's a little bit harder technically to manip.
Yeah.
So a lot of people have that barrier. So I guess I'd end it like this. A lot of people don't manip, and they seem to be doing fine, right? So clearly you don't need to manip, right? Or you know, a lot of people think manipulations help them achieve their goals faster too. That's great too. I guess I would just end with what I've been doing lately a little bit more is I think I will put people at end range of motion. So whether it be cervical, lumbar, even like a joint, end range of motion, and then work a little bit in that position, whether it's soft tissue, whether it's a deep breath, whatever it may be, in that end range position, and maybe even do like a grade 3-4 kind of like joint move. And in my mind, if they cavitate at that point, so they have like a pop that they have from there, then I don't need to do a thrust, which is I think the question. I don't need to do a thrust there. They cavitated with like a grade 3-4 manip because I put them at end range. In my mind, I think that means they got it. Right, versus me, like I can just go, well, bam, and just crack everything. But I feel like the majority of the time we end up manipulating the hypermobile joints, and the hypomobile one doesn't actually pop.
I think there's research for that too. That grade 4 and they controlled half and half, and some got high grade 3, grade 4, some got manips, and they both did fine.
Right. There's only one thing though, that if you think you needed the manip, the grade 4 doesn't work.
Right.
It's kind of interesting. So I like to, if it goes, it goes. And in my mind, then you got that one segment that needed to go because you put it in the right position and you gently worked on it and it manipulated. So I think that's kind of how we do it here. We're not against it, but I don't think it's a big part of our practice here. And again, I think we're doing fine. I know a lot of other people that's like kind of their bread and butter, and they do great with it too. So it's definitely a skill set you should look into. But I think it depends a lot on your patient population. right? So great. So another good question. Appreciate it. Head to MikeReinold.com, click on that podcast link, and you fill out the form to ask us questions. And we'll keep doing this, right, Mike?
See you on the next episode.